Once again, good morning, good afternoon, everybody, depending where you are on the globe. And we are waiting those few seconds more to give the opportunity to the participants to connect to this workshop that it's co-created by the Women's Brain Project. And I'm representing the Women's Brain Project today, together with the World Bank. So the first thing to say it is thank you very much to the World Bank for giving us the opportunity of co-creating this workshop about the critical role of sex and gender within the COVID-19 pandemic. I will say we slowly start about my person. I am Antonella Santuccione Ciada, one of the co-founder and the current CEO of the Women's Brain Project. I also have another role. I am an official employee of Biogen, which is an American biotech. And I am here representing today the Women's Brain Project. So the point of view I am sharing with you does not represent the one of my official employer. That said, we have also experts from all over the world with us today. And some of them are from the Women's Brain Project, some represent other organizations and the World Bank itself. So with me, we will have Dr. Maria Teresa Ferretti, co-founder and chief scientific officer of the Women's Brain Project. Dr. Marisha Makardima, she's the president of the Women's Brain Project and also working for the University of Lucerne in Switzerland. Then we have Mrs. Vambui Karanaya, and I hope I have pronounced the surname correctly. And she's from the Global Brain Health Institute. She's a psychologist and she's a volunteer for Alzheimer's disease and dementia organization within Kenya. And then we have our major host. She is Dr. Samira Al-Tuvai Jiri, and she's a global lead for population and development, as well as nutrition at a population level for the World Bank. Now, next, please. The objectives of this workshop are quite clear. We know that we are still confronted with the pandemic, that it is still impacting our lives on a daily basis. And we have also learned that sex and gender, which are often overlooked, nevertheless play a major role within the pandemic itself. And the workshop that is held by the Women's Brain Project and the World Bank today aims to highlight three key angles of sex and gender differences within the COVID-19 pandemic. The three angles will reflect sex and gender differences in the pandemic from a scientific and medical point of view. We will talk then about gender differences when looking at the socioeconomic impact of the pandemic on the global population. And finally, the perspective of a country like Kenya when it's about sex and gender in the Kenyan context. It's therefore going to be a country-specific example. So the final aim of this workshop, it is to empower all the listener and eventually those who will listen afterwards to the workshop with facts, with insights and teaching that might be helpful when navigating the challenges of the COVID-19 pandemic as an overall. Next slide, please. Next slides, please. I think we have some technical issue. We are waiting for the next slides, which will be related to the House ruling system. Erika from the World Bank, can I please kindly ask you for your support? Can we please have the next slide?
I'm bringing it up now.
Thank you. Bear with us. Here we are. This is about the House rules of the event today. And the kind request it is to remain on mute except when you are going to speak. We kindly ask you to eventually remove your video connection to increase the power of the bandwidth. We also would like to bring to your attention that this event is currently recorded. If you have any question, we are very glad to address them timely. And in order to do so, please write them in the chat box that you have available within our platform. If you have any difficulties with connection or with understanding, please write it in the chat box and we will assist you accordingly. The event that you're gonna be witnessing today and listening to, as well as the material, are a product of the staff of the IBRD World Bank and its external participants to the event. The finding, interpretation, conclusion expressed in this event do not necessarily reflect the views of the World Bank, the executive directors of the World Bank, or the governments that they would represent, that they represent. The World Bank does not guarantee the accuracy of the data included in this workshop, and the material should be reproduced or distributed. It should not be reproduced or distributed without the World Bank prior consent. So I hope that the house rules are clear. Next one, please. To make this event interactive and lively as much as possible, we have decided to introduce the concept of the Mentimeter. This is a tool that you can either open in an extra window or that you can simply have in one of your portable device. And you just have to write menti.com and insert the code that you see displayed here, or eventually use the QR code. The code number, it is 9657916. And by accessing the Mentimeter, you will be at some point asked with questions that you will be able to answer. And then together we will analyze the result. Next slide, please. About myself, I think I already mentioned who am I. I also want to emphasize once more that what I'm going to share with you does not reflect the opinion of my official employer, and it's my personal perspective. Next one, please. So, few words about the Women's Brain Project. The Women's Brain Project, as you see here in the slides, consists of a group of scientists from different type of disciplines, which would include medicine, neuroscience, psychology, pharmacy, communication. And we also have the presence and contribution, the very precious contribution of caregivers, patients, as well as their relatives. But we also work very closely with policymakers and other type of stakeholders that are present in the ecosystem of health, novel technology, and their implication on our well-being. Next one, please. What are we doing as a team of scientists, as a team of experts in the field? I think I am missing now the screen. There are some technical issues. If we can go, yes. Okay. We have a clear purpose, which is the one of transforming brain and mental diseases, mainly applying the concept of precision medicine. We work together, as we said, with the major key players because we believe that there is an opportunity to improve the stage of medical treatment as well as drug development and novel technology design for brain and mental health, considering the sex and gender differences to achieve what we call precision medicine. We believe that this is the gateway to precision medicine. Next one, please. I hope it's going to work. I'm very sorry for this. So I see here now an opportunity to interact with you. And as we explained, we can use...
Antonella, I'm sorry, may I interrupt? This is Anne-Marie. I'm back, I'm sharing my screen. Unfortunately, I cannot share my video and screen. So you will only hear me, but not see me, but that's fine. But I moved back again to our poll. So just to let you know what's happening. So I went back to our poll, Antonella, and then you can continue from where you paused. Is that okay? I'm very sorry about this.
I need a bit of guidance, Anne-Marie, sorry. Shall I now kick off the poll or has it been already kicked off?
I think it's kicked off. Can you see some of the answers on
yes,
screen?
That's why I'm asking.
Up. Yes, they're popping up on screen.
So the question was, where are you listening or watching this seminar from? Which country? And we are getting some answers already. We have quite some participants online, and I can already see that countries which are mentioned are UK, Scotland, England, Switzerland, Kenya, France, US, and I don't know if additional ones will come up. India, it's a new country listed here in this poll of questions. Yeah. I wonder if we're done with the answers. Okay. So I think we have a good representation of the diversity that it is present on this globe with the participants from different type of countries. And as we said at the beginning, the aim of this workshop it is really to empower each of us in understanding how sex and gender differences are having an influence on the pandemic. And this is kindly provided to you by the Women's Brain Project together with the World Bank. We were now talking about the Women's Brain Project, and I was mentioning to you that we are advocating and generating scientific evidences as why sex and gender will have an impact on brain and mental diseases. And this is why it has to be considered if we want to achieve what we define precision medicine. And why is this important? It is extremely important because we would like to increase the drug efficacy by considering sex and gender differences, but in fact any type of diversity or patient's characteristic as we define them. We would like to do so because we would like to improve drug safety profiles. We believe that considering sex and gender differences and beyond, the safety of our medicines can be definitely improved. We would like to also increase the therapy adherence and compliance. This is absolutely an issue that it's known to doctors, drug developers, and healthcare professionals in general, that very often people stop to take the medication because maybe they don't see a good effect. And the adherence, it is a major issue, especially in brain and mental diseases. Then, of course, this all consideration will have a very meaningful impact on reduction of costs, which are associated to a possible failure of drugs. So in the end, it's also making healthcare system more sustainable. And this will happen, this will allow to have a transition from what we define shallow medicine towards precision medicine to achieve what we just mentioned being a pillar of the UN priority as sustainability as an whole. Next one, please. So we are very strong, as we said, in brain and mental health. We learn, nevertheless, that sex and gender differences plays a major role also in the pandemic, but actually they are reflected in all the field of medicine. We are focused, nevertheless, on topics such as Alzheimer's disease, where we can define ourselves as specialists on the topic with a global impact. This is the type of work that we generate. We produce scientific evidences that gets, of course, shared with the scientific community with peer-reviewed publications. And we provide, as we said, scientific facts as why sex and gender will have an impact on brain and mental diseases. We started in 2018 with one of our major work published on Nature Neurology Review, and then we went beyond with many more publications. These are the ones in our pipeline for 2020-2021. We have also touched the topics specific to the pandemics, and we've used our knowledge to address the need of having the consideration of precision medicine when managing also a pandemic. We also, of course, produce books. We are currently writing 2 books with the publishing house Elsevier that will cover the topic of sex and gender differences in Alzheimer's disease, but also sex and gender differences in digital health, referring then to the digitalization of medicine that we are experiencing on a daily basis and even in an advanced fashion, mainly because of the pandemic as well. We have also several scientific collaboration which really cover the whole globe, ranging from academia to drug developers and even non-profit organizations like ours. Next one, please. What is also another output of the work of the Women's Brain Project, it is the International Forum on Women's Brain and Mental Health as the gateway to precision medicine. In 2020, we had the challenge of having our 3rd forum in a virtual fashion. It was, I will say, one of the first virtual broadcasted events that had almost a TV setting. We are very proud of the guests that joined the event, which range from FDA to guests from the OECD, of course, the academic community, patients, organizations, patients themselves. But let's be frank, one day we will all be patients. So each of us have a huge responsibility in shaping the agenda. And yeah, so we are getting ready for the next edition, which highly likely will happen in 2022. Next one, please. This is the type of coverage we have. This is the type of engagement we have. I have to say that the strength of the organization, it is also to share our scientific evidences with the broader public. And this is at the core of the work we do. We want to empower people with scientific knowledge that will improve their well-being, their way of living, and their understanding of science and medicine. And this happens with collaboration with the media, major media around the world, but also with scientific media. As we mentioned, we publish on a regular basis about scientific evidences. And this results luckily also in recognition, which brought us to some type of awards. The most important will be the one we had in 2020, winning the World Sustainability Award, which is a dear piece for us because it shows that considering diversity and differences in medicine will render healthcare system more sustainable. Next one, please. These are our partners. These are our collaborators, our sponsors. It's a big, common, shared effort. And I have to say, which I didn't mention earlier, that the majority of the scientists which are working for the Women's Brain Project, they are doing it on a pro bono fashion. Our final goal today, it is to establish the first Sex and Gender Precision Medicine Research Institute worldwide, which will be in Switzerland, but which will have a global reach out. So it's a journey, and we have many partners, many sponsors, many friends that are giving us company along this journey. We are very thankful and, of course, very happy that this is what we have. Now we go at the core of our conversation for today after I gave you this introduction, and I am very happy to introduce you, first of all, to a friend, and second, to a very distinguished scientist who is the Chief Scientific Officer of the Women's Brain Project. Her name is Dr. Marisha Ferretti. She's a neuroscientist and neuroimmunologist. She is an expert in the field of Alzheimer's disease, and she's also one of the co-founders of the Women's Brain Project. She was one of the first to trust in this journey in 2016 with us. That said, I'm very happy to give you the word, Maria Teresa, and yeah, I am very glad to the next conversation. Thank you.
Thank you, Antonella, and good morning and good evening to everybody. It's a pleasure to be here. In the next slides, in the next minutes, we will really dive into the sex and gender differences in the pandemic. We will spend quite a lot of time talking about it. But before we start, we thought of proposing you this poll just to see what is your baseline awareness of these sex and gender differences. Are you aware of sex and gender differences in COVID, or you never heard about them? or maybe you heard something, you read something, and you would like to learn more about it. So you can use the Mentimeter tool. So you can type in www.menti.com and use the code to actually give your answer. And I'm going to wait just a couple of seconds to have more or less an idea. And I can see that at the moment, most people responding to the poll say yes. So that's very good. It's actually a very good sign. But we also have some no and some kind of. So this webinar is for everybody, of course. So I think we can move to the next slide. So spoiler, yes, there are sex and gender differences in COVID. The first sex and gender differences actually emerged already from the Chinese data that were shared by the Chinese medical authorities about 1 year ago. And I'm very proud to say that the Women's Brain Project was actually one of the first organizations in the world to highlight and to note that by reading carefully the graphs and the tables, there was a very obvious difference between men and women, especially in the mortality to COVID. So that was the very first sex and gender differences that we noticed. And since then, this trend has been confirmed in many other countries. And the data I'm showing you here in this slide are actually global data. So aggregated data by over 150 countries. This is an analysis done by Global Health 50/50. And what I would like to show you with this graph is that actually for every 10 cases, female cases, so the purple one, you have, as you can see, about 10 male cases. So the number of cases of COVID at the global level are not different between men and women. So we are both getting the disease at the same rate. However, I'm sure you can appreciate how many blue squares you have for ICU admissions, deaths, and confirmed cases that died. So there is an overwhelming, quite significant difference in terms of severity of the disease, so ICU admission and also death, indicating a male vulnerability. And so this is really, as the poll has shown, there is high awareness on this type of differences. Many people are aware of this and other differences we will be talking about. And I think this is important because the pandemic has just brought to the spotlight something that is not unique to COVID-19, because these differences between men and women in pathologies actually occur in almost any disease you can think of. So the pandemic is a great opportunity to actually talk about these sex and gender differences, try to understand them, and learning a lesson that can be applied to medicine at large. So if I can have the next slide, please. You will hear about both sex and gender during this webinar. My job is to tell you about sex differences, and Marisha Makardima will be focusing on gender differences. So what do we mean with these two? Just to give you definitions so we are all on the same page. When I'm referring to sex differences, I'm talking about biological differences between men and women. So differences that are driven by the expression of sexual chromosomes and sexual hormones. On the other hand, gender differences are due to socio-cultural constructs. So they're different from a society to another, are related to the role that a man or a woman have in a given society. But very importantly, they both have an impact on health. And it's not just me saying it, but it's actually the WHO. So when we try and understand what's happening, why men and women are showing this different vulnerability in COVID, we have to try and understand both aspects. So I will be focusing on sex differences, so biological aspects, in the next couple of slides. So in the next slide, I would like to quickly discuss one of the great classics of gender medicine, which is sex differences in the immune response. This is actually something that I think might explain a lot, this differential vulnerability between men and women from a biological standpoint. We do know very well in medicine that the immune response in men and women is different. In general, women mount a stronger immune response, stronger against viruses and pathogens at large. This was also shown already, this differential vulnerability was already known in SARS and MERS, so it's not unique to COVID. And so women tend to have this stronger immune response, so they seem to be protected against some infections. But this is a double-edged sword, because the other side of this thing is that actually women are at higher risk for autoimmune disorders. And you might know that 80% of patients with multiple sclerosis or lupus are actually women. So we do have these fundamental differences in a biological function between men and women. And actually, this has been investigated in COVID. And I'm showing you here one of the most influential papers in this field that has actually undertook a very extensive and and deep analysis of various aspects of immune response between men and women. And what this paper shows, and other studies have confirmed, is that men seem to show a higher expression of inflammatory cytokines, especially interleukin-8 and interleukin-18, while women have a stronger T-cell response, so a protective immune reaction. Men, therefore, tend to show a higher, it's called an innate immune response with these cytokines, which are chemical mediators that normally orchestrate an immune response, but if they go on override, they can actually induce detrimental effects. And that's what we see in this famous cytokine storm you might have heard. So you have an uncontrolled inflammatory reaction that actually creates organ damage, for instance, in the lungs. So men seem to be at higher risk for that. And I think these observations are extremely interesting for two reasons, because on one hand, they can actually teach us something about how the human body responds to the virus. And by studying the sex and gender, the sex differences, we might actually understand something about really the biology of this virus. On the other hand, beyond basic science, I really think that once we pinpoint this type of differences in biological processes between men and women, that could be the basis for precision medicine in treatments. Because at that point, if you identify a subgroup of patients that overexpress a specific cytokine, and that could be men, you might want to tailor treatments to that subgroup of patients, and that same treatment might be actually less effective in another group of patients. So you really want to tailor the treatment. So that's one example of how relevant this can be. In the next slide, I want to bring up the topic of comorbidities, because that has been also mentioned quite a few times to explain this differential vulnerability between men and women. Because you can think, if you have one comorbidity that is associated with higher risk of death, and if this comorbidity is happening more often in men, that could be a very easy explanation of why men tend to die more of COVID. There isn't such a clear picture, to be honest with you, in the literature, but I'm showing you some data from the Italian authorities, because they have shown stratified data for men and women. And what I hope you can appreciate from this table is that there is kind of an equal distribution of comorbidities. Some are more common in men who died with COVID, for instance, ischemic heart disease, and some are more common in women, for instance, hypertension. There is not a very clear cut. Obesity, for instance, is equal between men and women. However, I do think there is a lesson to learn here as well, and it's related to the relative to risk factors. So I think what we should learn and we should study, and we are starting to understand thanks to the pandemic, is that you have different risk factors that can affect different people in different ways. And we might want to really study this data and understand what is a comorbidity that is more associated with death, maybe in men, and one that is more in women, because that might inform and instruct strategies for tailored, again, primary and secondary preventative strategies. So you might want to identify and know exactly the characteristic of a patient that is a high risk to be able to monitor this patient and follow up on this person. And in the next slide, if I can have it, it's the final point that I wanted to make. It's about vaccinations, a very hot topic right now. There are at least two considerations related to vaccination and sex differences. One is very much a consequence of what I just told you about the immune system, and this is that it is very well known that women mount a stronger antibody response after vaccination. So if you give the same dose to a man and to a woman, the woman will respond. We have a heightened response to the vaccine. This is very well known in the field. There was never any action that was taken for this. I mean, we never had adjustment of doses because of sex. But I think maybe the pandemic might be a good chance to actually discuss this. We might want to, again, adapt and adjust doses for different categories of patients, and especially looking if we want to reduce side effects. And even more pressing, I think, is the issue that now it's present in the press as well, of pregnant and lactating women and how to treat them and whether to vaccinate them. These groups were actually excluded from the clinical development of vaccines. And the result is that we don't really know whether the vaccine works in them, and most importantly, whether it's safe. So they were, of course, excluded from clinical development to protect them, but the final result is that the moment they fall ill with COVID, there is no evidence-based medicine to tell us and to guide the therapeutic decision. So some regulatory agencies are just forbidding the use because of lack of evidence. Some others are recommending the use in risk cases. But this is a huge issue, and I just want to highlight that it's not unique to COVID. This is actually an issue that happens with every single drug on the market, because it's a standard procedure to exclude pregnant and lactating women to protect them. But as I said, this creates a gap in knowledge. And I think maybe with the pandemic, we are all realizing that this is an issue and a pressing one. And so this might be a good opportunity to reconsider the way we design trials, and maybe to implement the creation of registries and epidemiological tools to follow up treatment in these groups and create some evidence. So I have a concluding slide, the next one, where I just want to put everything together. I hope I convinced you that the pandemic is actually an incredible chance for us to consider, to look at these sex differences, the biological ones I'm talking about particularly, to initiate a change that is needed overall in medicine, and is the change from the one-size-fits-all medicine to precision medicine. And I think this is something we have realized, all of us, during the pandemic, that you don't have two patients that are the same virus. You will have one person that is positive to the virus and is asymptomatic, and you will have another person that will actually need ICU hospitalization. So completely different responses. So we really need to understand what are the characteristics of the individuals that are at higher risk and will go on to be ICU admitted. And some of these characteristics will be and are, we already know, they are linked to sex. So we have to stop considering all patients like one group and really start implementing precision medicine based on molecular diagnosis to achieve individual level risk assessment, prevention, prognosis, and optimize treatment in clinical trials. The big question, of course, is how do we do that? So I have in my last slide a little bit of future direction. The way forward, according to the Women's Brain Project philosophy and view and vision, is actually artificial intelligence. We are profoundly convinced that to implement precision medicine, we will need artificial intelligence, we will need digital solutions, we will need predictive algorithms. So this is definitely the future, but of course it's not easy. And we are very active in this field with several publications to talk about, the potential of this approach, but also some aspects that we have to be very careful about, like bias in the data. So I encourage you to check our papers, as well as an upcoming book. It was mentioned by Antonella. I'm showing you here the preliminary cover, which I think is beautiful, of a book on sex and gender bias in technology and artificial intelligence applied to biomedicine and healthcare. Will be available as of August. So I thank you for your attention. And the next speaker, I'm very, very happy to introduce to you again a very good friend and a colleague and a very distinct scientist, is Dr. Marisha Makardima. She was, together with us, a co-founder of Women's Brain Project. She's currently serving as the president, and she's a health psychologist currently working at the University of Lucerne. And she will be talking about gender differences from a socioeconomic standpoint. So Anne-Marie, to you.
Thank you, Maria Teresa. Thank you for the kind introduction. So before I actually start talking about gender differences related to the impact of COVID, the COVID pandemic on mental health, I would like to know what comes to your mind when you think of this topic. Once again, I ask you to go to the menti.com page. You should refresh the page and you will see the question. You can input up to 3 words that you associate with the impact of COVID-19 on mental health. And we will be working on this word cloud together, or creating a word cloud together. I see 22 people, 24 people have already responded. Right in the middle, the larger, just for you to know if you have never worked with a word cloud, the larger the word, that means that more than one person has, for example, inputted the word anxiety. So I see that anxiety is one of the most frequent topics that come to mind when thinking of the impact of COVID-19 on mental health. Isolation has also been talked about a lot in the media, loneliness, depression, stress, fatigue, burnout, panic attacks, caring responsibilities, suicide thoughts, cardiovascular, despair. So yes, there is a lot to talk about. I will be mentioning a lot of these topics in my input. I am mindful of the time, so I hope I will manage to cover most of what we can see in this word cloud. Thank you. That's a very impressive word cloud. Money problems. That's also something I would like to mention. Great. So I'll move on to the next slide. So the impact of COVID-19 on mental health. So before the pandemic, mental health has always been an issue, just like our physical health. And when we look at the general impact of the pandemic, we usually compare to the time pre-pandemic. When we look at the risk factors related to mental health issues, one of them is being female, unfortunately, low income, low education, a history of psychiatric illness. These risk factors, along with some new ones, have been amplified with the pandemic. So we have the existing risk factors like low income that have been amplified, as well as new risk factors that have emerged during the pandemic, such as isolation and boredom, two words that were also mentioned in the word cloud, inadequate supplies or information or lack of access. So COVID has magnified the risk and also the prevalence of mental health issues. And that is in general. So when we talk about the gendered impact, so the differences between men and women, when we look at the impact of the pandemic on our mental health, we see some differences. And this time it goes in a different direction than the sex differences mentioned by Maria Teresa. We look at the risk groups or the vulnerable groups, and in most of these groups, unfortunately, women are overrepresented. So I will mention a few examples, since there are a lot of examples to talk about. Let's take responsibilities of care. Here we have women are overrepresented. So when it comes to child care or care of other family members, in most cases, the majority of the persons who are responsible for care are women. And now these responsibilities are impacted by the COVID pandemic due to isolation or the closing of schools, for example, homeschooling. And studies carried out in these last months, further to the start of the pandemic, report that, for example, 1 in 4 women feel burnt out. One study carried out in the US reports that women with children are more likely to report symptoms of anxiety or depression than men with children. I also want to mention a statement issued in by Europe in a plenary session at the European Parliament last January, so just a couple of weeks ago. And one of the things they mentioned was that working from home is not a substitute for childcare. So simply the possibility of working in home office does not mean that someone can easily take care of the children with their homeschooling and so on. And this is an important point to mention. Other risk groups or vulnerable groups that have been hit hard by the COVID pandemic are victims of domestic violence. Here again, most of the victims of domestic violence are women. We have reports that there is an increase in frequency and severity. The United Nations report that the number of calls to services, to helplines, has doubled since the start of the pandemic. And due to the lockdown and to the limitations of social contact, a lot of victims find it hard to find safe spaces that take them away from the perpetrators. Another risk factor or vulnerable group are people with low or no income. Unfortunately, a consequence of the pandemic is unemployment. So a lot of people have lost their jobs or are working in reduced hours, leading to lower or no income. And we know that unemployment is linked with mental health issues. So this is also an important point to think about. And last but not least, I want to mention the healthcare workers, the frontline workers. Again, here women are overrepresented, and I will talk in more detail about this in a later slide. So the economic impacts of COVID-19. So we have seen that unemployment has risen in this last year since the pandemic started. New job opportunities are quite low, and in most cases, in many countries, we read reports that when it comes to people losing their jobs, women have a higher risk of losing their job, of being unemployed. They are also more likely to actively leave their employment or to reduce their hours due to family responsibilities during the pandemic. So this is also something that perhaps with new measures, with new policy, could be addressed for women to be able to keep their jobs while juggling homeschooling and other consequences of the pandemic. And we know that women, they are already more likely to live in poverty, and now this added impact of the pandemic has increased this risk of women living in poverty or living close to the poverty line. So this is something that we need to be aware of even when considering new measures or new interventions to combat the impact of COVID-19 on our mental health. Another point, when we talk about COVID-19 and the impact on new mothers or pregnant women, Teresa mentioned the physical aspect of this when we talk about vaccinations or lack of knowledge about how to treat COVID infections in pregnant or lactating women. We also have the other aspect of the pandemic, and this is the impact on women's mental health when we talk about the perinatal phase. There is this very popular saying about it takes a village to raise a child. And now we are being isolated from this village. When we, with social distancing, lockdown, women, new mothers or pregnant women do not have the available social network or social support that they usually have. So isolation, loneliness, that is a huge risk factor. We also know that one of the most common mental health issues in the perinatal phase is postpartum depression. Loneliness, isolation, perhaps lack of or less contact with professionals are all risk factors for postpartum depression. So we need to be aware of this, not just as professionals, but also as members of society. We just need to look around us and be aware that maybe someone in our network who is expecting a baby or is a new mom would need some some alternative mode of support. There are various suggestions for the future, and this is also something that has been added in reports, that we need to develop alternative ways to support new moms and pregnant women, for example, through telehealth and other innovative ways. Another vulnerable group when we talk about the impact of COVID-19 on mental health are caregivers. And there are two groups of caregivers. There are the formal caregivers, that means the employed caregivers, frontline workers, so people working in the health sector. And then there are the informal caregivers, that means people who are taking care perhaps of a family member who is unwell, and who are receiving no remuneration. And both these groups are being impacted, are being hit hard by the pandemic, and in both groups, women are overrepresented. When we look at people working in the healthcare sector, 70% of the global healthcare workforce are women. This was reported in a World Health Organization report in 2019 that was aptly titled "Delivered by Women, Led by Men." Why? Because when it came to people working in clinical practice with people in the healthcare sector, 70% were women. But then when they looked at decision makers or persons in a leadership position in the healthcare sector, only 25% were women. So we have a lot of frontline workers who are women, and we know, as we have seen also in the media during the pandemic, frontline workers have been exposed to high stress, to high anxiety. They are reporting burnout, and they also have to face the anxiety of being exposed to the COVID virus, and also to the risk of them taking this virus back home with them and maybe passing it on to their loved ones. So this is a big issue. We need to take care of our frontline workers and make sure that while they take care of us, we take care of them. And this is the same for informal caregivers. Even before the pandemic, there was, this has been reported that most of the informal caregivers, that means people taking care of family members or friends, the majority are women. And this is a consistent finding across cultures and countries. And we also see differences between male and female caregivers. Even before the pandemic, female caregivers reported more caregiver burnout, more stress, higher anxiety, more symptoms of depression. I cannot talk in too much detail about this as I'm mindful of the time, but there are various explanations, and one of them is that women are more intense, they spend more hours taking care, they take care of more intimate needs of the patient, and there are also higher expectations, and they also have different coping strategies. Now, the pandemic has added extra stress for informal caregivers. There is less access to services. Even services that they were using are maybe not available anymore. A lot of caregivers had to isolate themselves to protect the person they are taking care of. So this adds extra anxiety, extra stress, and has a significant impact on their mental health. A last point I would like to make is a question that I'm often asked, because there was this post or article circulating even on social media. Do women make better leaders? You know, in the pandemic, there were some statements that female leaders have dealt better with the pandemic. Before trying to answer this tricky question, I would like to turn the question to you. What do you think do women really make better leaders? Okay, so I see the first answers coming in. Most of the answers say yes. Okay, so at the moment we have 12 for yes, 1 for no, and 4 for equally likely. Any more answers? Okay, so as I said, this is a tricky question, and I don't think we can answer yes or no. And there have been a couple of studies now during the pandemic about this phenomenon. Are female leaders, have they been more effective or more successful in dealing with the pandemic in their countries? One study found no evidence that women, female leaders were better or faster to implement measures. So after looking at male and female leaders and comparing, they did not find any significant differences. Another study found differences, and here one of the difference was in the style, in the leadership style. So a probable influence of these differences was that female leaders went for a lockdown earlier than male leaders. And various literature suggests gender differences in leadership style. And this may have an effect on, obviously, the decisions that are taken by leaders and the effect consequences of this decision. So I hope not to disappoint you by not answering this question by yes or no, because I don't think it's a yes or no answer. I think it's just a matter of leadership style. So we see that there are differences in leadership styles, and this obviously has an impact on how men and women lead, even when it comes to leading countries. And as a side note, but not less important, is that various governments have shifted their priorities for the time being during the pandemic to from the non-essential, for example, the reproductive healthcare services, to focus more on COVID-19 related healthcare. And this is obviously, in my opinion, and in our opinion, I think I can speak for Women's Brain Project, not the way forward. I don't think one is less important than the other. So in a nutshell, that was what I wanted to mention when talking about gender differences and the impact of COVID-19 on our mental health. And here I will move on to Wambui, who will be talking about COVID-19 with focus on the Kenyan context. So welcome, Wambui, and I pass the mic to you.
Thank you so much. And I just want to say that I'm very happy to be joining this meeting and to be listening in and to be learning so much from the Women's Brain Project. And I'm glad to be invited to give a Kenyan context. And before I start, I'll say that this is just my idea on what has been happening on gender and sex differences in Kenya, but it's a very nuanced and very diverse country, and the truth might be more than what I say. So it's just more of what I've observed and what I think. So yeah. And I'll start with a quote from one of my favorite writers, Audre Lorde, who says that difference must not be merely tolerated, but seen as a fund for necessary polarities between which our creativity can spark, like a dialectic. And I think that's the work that the Women's Brain Project is doing, that considering difference and creatively to serve population. And I think that's quite important work. I'd like to give a shout out to Anna Bruga. I hope I said your name correct, and Mageda, who I know from previous work and have joined me today. So just a brief background on Kenya. Kenya is a country in Eastern Africa, and according to the 2019 census, there's around 47 million people, and there's 23 million males, and you can see the numbers, and 24 million females. And for the first time in the Kenyan census, there was an inclusion of the counting of intersex persons in Kenya. So that was really interesting. So there's 47 counties in Kenya, and I'll add that health is a devolved function in the county government. Around 68% of the population in Kenya lives in rural areas, and around that 2% live in urban areas. And among that population that lives in urban areas also commutes between the urban areas, going through and coming to work. So, and the Kenyans' life expectancy, according to the World Bank, in 2018 is 66. And as you all know, some of the best athletes in the world come from Kenya. Next slide, please. So the knowledge and awareness of COVID-19, according to the Kenya National Bureau of Statistics, they did this survey whereby they found that in May, at least 99.4% of Kenyans had of coronavirus. And what's interesting to note is that how these people had heard about COVID-19 in Kenya is through radio, which is one of the ways that we use to gather information and to know. And even though there are more than 40 vernacular languages or local languages spoken in ethnic communities, there's at least a radio station for each of those languages. So the penetration on awareness and knowledge of COVID-19 really went into the communities early and effectively. So the knowledge on protective measures against COVID-19 and washing with soaps and water, that's what people knew about, and about the measures. So in addition to these, those drastic measures taken to curb COVID-19, there's closure of borders, closure of schools, there's travel restrictions between urban areas and rural areas, and people changed, really, their behaviors changed. And before when the pandemic started, I was living in Dublin. When I came back, everybody was doing fist bumps. So that in the beginning, we used to shake hands. We loved shaking hands, but now everybody greets each other by fist bumps or just waving. So you can see how COVID has changed behavior of people across the world. There's been massive loss of jobs. And considering that the bigger population works in informal work that was kind of like just scaled down and went back because of lockdowns and restrictions, there's massive job losses. And also there was there wasn't enough really to protect those vulnerable populations. So there's a big disruption to daily life, like it has been everywhere else. And one thing I'd like to add is that after the restrictions there was an increase in police violence because police were used to ensure that people are following the COVID restrictions, which increased fear and anxiety in the population. Next slide, please. So I think I was going to use this slide before this, but it came after. So we'll just skip that for today. I was going to ask you what you thought the percentage of COVID-19 was. So there's this lovely article from John Allan Namu, who's an investigative journalist, who talks about To Eat or To Heal and the impact of lockdowns in Kenya. And it's obviously that that COVID-19 was much harder on low-income households and people who depended on who worked at night, people who depended on wealthier parts of Nairobi, which were closed down and couldn't be accessed from informal areas, really suffered from this. There's someone else who's written about washer women in Nairobi, whereby it's women from informal settlements who go and sit around areas in Nairobi, in wealthier parts of Nairobi, and wait for someone to call them so that they can do the cleaning in the houses. And what will they say in this context of the pandemic? And it's really interesting, and I might share a link later. So for now, like what COVID-19 is going on in Kenya, I think one of the biggest myths is COVID-19 isn't real. And even though we've seen all those measures, there's with Tanzania, our neighboring country, refusing to acknowledge COVID-19 for all those months until now. Recently, I think this past week, that's when President Magufuli actually called for a 3-day of national prayer in Tanzania to talk about COVID-19, but then he didn't enforce the measures that have been recommended by the World Health Organization. So I think that idea like crossed over to Kenya, and people have been like, is there really COVID-19 in Kenya? And in the past 2 weeks, I've been going to the national hospital here in Kenya almost daily, and it's almost like there's no COVID-19. There's crowded lifts, there's people just live like pre-COVID times, and I don't know, I think the fear and the restrictions and the behavior around COVID-19 has really changed right now. I don't know what will happen next, and I'm hoping there are no more cases, even though we are seeing more cases are increasing. But I was going to say that in the beginning, there's this question that people asked each other. Do you know somebody who knows somebody who knows somebody who has COVID-19? I couldn't say that around August, but right now I can say that I know people who had COVID-19 in the country, and I know how scary it is. And there are more people there. Up to now, there are people who don't know anyone who has who's had COVID-19, and they're like, is it really real? Next slide, please. So up to date in Kenya, there has been 104 confirmed cases of COVID-19. So those are the ones that have been tested, but there's complaints about whether Kenya is Kenya really testing enough to know the number of cases. So there's total recovered cases of 85,665 as of yesterday, and 1,837 deaths. And really, like, I don't know that these are the real numbers. And like, as you can see, the government releases this infographic every single day on the Ministry of Health's Twitter page and social media pages. And as you can see, it's just the numbers of people, just numbers. And you can see there's no representation of gender and what's really happening on the ground, where the cases are, which part of the country they are. So that has just led to a really big mistrust in the government and how it's implementing, coupled with cases of corruption and loss of funds in the Ministry of Health. That money was supposed to help with COVID problems. So the other thing I would add is that the government used COVID-19 as a scapegoat to not implement some of the very, very important bills that were in Parliament that will have really benefited women. And I really want to thank Mageda for bringing that to my attention. And so COVID-19 has really just led to whereby there's this progress and people doing a lot of activism and advocacy work to bring changes to the country, but then COVID-19 was also used as an excuse to not implement some of those changes. Next slide, please. So as we know, everywhere there has been an increase in gender-based violence as a result of COVID-19 and people being at home. And one of the things that we're not talking about enough is cyberbullying. And a lot of people moved online after the restrictions. People are working from home and being online, using the social media much more. And one thing we've seen is that women have really been bullied online, and really like sexualized violence against women digitally has really increased. There's also been an increase in teenage pregnancy, and you see all these headlines everywhere. Like this one, alarm is 3,964 girls impregnated in Chaco County in the month. And so these girls are teenage girls, they are underage, they're blamed for their pregnancies, but then we don't really talk about the trauma they're experiencing. Some of them, and most of them, have been raped by close relatives and people in the community, and in such times they can't get the justice, and most of the time it's the health care that they need. So this just shows that there's an increase in trauma and mental health issues that we'll see in the coming years with the girls as a result of COVID-19. So there's been an increase in maternal and child deaths due to an increase in difficulty accessing sexual and reproductive health services. And I remember one of the speakers mentioning postpartum depression. And if you experience giving birth in such difficult conditions, your risk for getting postpartum depression increases really. So even though we talk about maternal and child deaths, we don't talk about the challenges, the mental health challenges that are left with women all over the world, really, as a result of all these restrictions and changes and lack of services that are not considered for women. Next, please. So my background as a psychologist, in the last 4 years, I've worked with people with dementia and caregivers of people with dementia. So in the middle of the pandemic, actually in the beginning of the pandemic, we started having online support groups because we couldn't meet. So we used to have Zoom support groups for caregivers of people with dementia in Kenya. And around August, we got a small grant to create a caregiver course for people with dementia, for family carers of people with dementia. So before developing the course, we did this very short survey to just understand what caregivers were going through. So this is just one of the slides. We just moved from Google Forms to here. So the first question we had asked them: has COVID-19 affected your caregiving role? And most of the caregivers said yes, others said no. And how caregivers were affected, there was a big effect on the emotional well-being, some of them on physical health, financial constraints, a really big problem for family carers who are often unpaid, and social isolation, because some of these carers live in rural areas and they depend on other family members who live in urban areas to offer support sometimes, and sometimes they couldn't travel. There's also caregivers not being able to come in if you have like someone who helps you take care of a person with dementia. They couldn't come in sometimes. So yeah, so this is very insightful what's going on with carers of people with dementia in Kenya. Next, please. So and just to give a background on like some of the really interesting initiatives that came up after COVID-19 support each other. There's this really interesting group, and you can follow them on Twitter at TransQueerK, which from March to October 2020, they had raised about 1.8 million Kenya shillings, which is around more than $1,500 US, I think, to support transgender and queer people in Nairobi who often, even during the pandemic, you've seen like an increase in violence against trans and queer people in Kenya. So LVCT Health, which is an NGO in Kenya, adopted and started mentorship programs to girls and virtual education and disseminating crucial information on the pandemic. And one interesting thing about LVCT Health is that when they were, some of the information sharing was not just about the COVID-19 itself. It was about protecting yourself against gender-based violence and just creating all these measures for girls so that they couldn't go out and be exploited. And I sound like I'm blaming the girls, but they live in a society where we have to constantly look out for ourselves as women. So just really good work done by LVCT Health. And and Wheels for Life is an initiative that was started by a doctor in Kenyatta National Hospital. And because many women in the area, not in the rural areas, in the informal places in Nairobi, informal settlements in Nairobi, they're not going to hospital because of fear to deliver. And she started this lovely project to support these women, and where they could make a call and she could go to them and advise them on what to do, and just give really crucial support for women who needed to give birth around this time. So I think that will be it, and thank you so much for having me. I hope you learned something from me. And I'd like to introduce Dr. Samira, who will be the discussant. Thank you.
I was muted, I'm sorry. Thank you so much, ladies, for the interventions. And it's really an honor and a pleasure to have all of this information this morning. For the sake of time, because I'm cognizant that we only have a few minutes and we would really like to leave some space for questions and answers, I am just going to make a few points. The first one is that the social determinants of health had always been, they've been real, impactful, and also they've been overlooked. So, and gender, of course, is one of them. But luckily, in the literature, this whole thing of the gender and sex differences within the pandemics and other health aspects had been gaining momentum simply because of the socioeconomic impact that we have on that, and that's a welcome change. On the essential health services, it's just probably another reflection of how fragile the progress that have been made. Because the first thing that actually flew out of the window is let's repurpose all of these service outlets, if you will, in the mainstream of the COVID work. The testing, the vaccines later on. And this is not an F or, and it's not something that can be easily exchanged for something else, because I don't know if you were aware of the Lancet work that came out sometime, I think it was last summer, forecasting the numbers of the very basic indicators that we thought that we have been mastering, under 5 mortality, infant mortality, and maternal mortality are going to be doubled and tripled and quadrupled simply because of the lack of access to the essential health services. And this is also a demand and supply thing. I mean, women are hesitant to go to the hospitals because hospitals are, hot spots for infections. And at the same time, some of these community centers are also repurposed in the service of the vaccine. And of course, we've heard a lot about the burden of care and the socioeconomics of the unpaid leave. I am not going to reiterate this. I think the colleagues have done a very beautiful job. I just wanted to take a minute to talk about what we're doing at the World Bank in terms of the gender dimensions of our work. So we're laser focused actually on all of these gender dimensions and gender as an important differential in all aspects of our work, be it an analytical or operational. And in the operational work, we're also focused on on the project cycle. So we actually invite teams to use something we call the gender tagging, which is really looking at what the gender gap is there within the cohort of population that we are trying to serve, and then find measures within the project components to address that gap, and then have indicators in the results framework to also look at the how the proposed interventions are actually going to be serving in reducing the gap, and how the progress that's this country is making, or this particular part of the country is making. And we're getting a lot of traction. We're getting a lot of enthusiasm and uptake by our teams. Pandemics are not easy to navigate, not just because of the social determinants of health and access and equity. They actually cut across everything we're trying to do, and among which is this whole efforts of our work on the universal health coverage, for example. And I think never before this particular aspect of the health system and the healthcare delivery system had been more important. So is the primary healthcare chain, acting as the filter or the gatekeeper into how people are going to be benefiting from all of these services, and how we can actually balance the demand and supply and all the economic and the social dynamics that are in the middle. So I'll stop here, and I will invite your questions. If you have a question and you've put it in the chat box, I'd be happy to read it. Otherwise, I think we do have a couple of minutes for your questions to be delivered in person. So if you have a question, can you please raise your hand? I have a question from Mark Heckler, our colleague, and it reads, does the adverse impact on new mothers mean that priority for vaccines should include pregnant/lactating women, or should policy be to discourage pregnant lactating women from getting the vaccine, given the lack of testing referred to earlier? Anyone who would like to take this? Maybe Anne-Marie?
It took me some time to unmute. Sorry. Well, I think this is more a question for Maria Teresa, who talked about the clinical development and aspect of vaccinations. From my side, what I can say from a socio-economic aspect is that this lack of knowledge is limited, and I don't think that it's very difficult for policy to be developed about this if we have no knowledge, if we have no data. I think data comes first, and then we can base policy development, policy transformation, as well as other strategies on the data, on the knowledge we gather. I'm sure Maria Teresa would like to perhaps comment about this too.
Yes, thanks for the question. And I agree with you, Anne-Marie. I'm actually reading carefully the question, and I'm wondering, when Mark is talking about adverse impact on new mothers, what we're thinking about, because what comes to my mind is mostly the issues that you've been mentioning about mental health and the strain, the burden, the caregiving and all that. And I'm not sure vaccines would help in that situation. So in general, I think there should be policies to support new mothers, that's for sure, from the perinatal period, the birth itself, until then the first years of life. Now in this critical period where mothers are under extreme stress. But for the vaccines, yeah, I think for policies, we really need a global discussion and data to come to some conclusion.
Thank you very much. I was also struggling to unmute. And I mean, I have a follow-up question to this, and I'm a gynecologist by training, so I looked a lot after pregnant women. If the ethical protocol actually excludes pregnant and lactating women from clinical trials to begin with, and that's an umbrella, how do we actually navigate this in terms of pandemics? Because then we're talking about life and death rather than, you know, immunity and protection. And granted, many other vaccines are also making the difference between life and death. But when it comes to community infections, it's something else. So how do we actually navigate that barrier in the platform that we're so used to, forbidding us from actually testing on pregnant women and lactating women?
I mean, I don't know who wants to answer that, but I can give you my feedback, and that's that this is really one of the biggest questions, in my opinion, in sex and gender medicine at large, not just for the pandemic. It's just that the pandemic has made this such an emergency. So I think right now, what I was suggesting also on my slide is that we should promote and implement registries, because pregnant women have been treated with a vaccine in emergency situations. There are some regulatory agencies that have allowed the treatment in risk populations. So there are pregnant and lactating women that are receiving the vaccine, and then we can have registries and follow up on an epidemiological level with pharmacovigilance, basically, to see what happened with them. That's something that can be done now. But I really think we have to reconsider the whole way we design clinical trials because of this. We really need a discussion. And I have to say, we are starting this discussion with regulators, with the Women's Brain Project. We are organizing a series of roundtables with regulators to really highlight these issues and propose a roadmap to move forward, you know, to implement precision medicine and women's health. So let's see, maybe there will be some change in the future.
Thank you. Yeah, it's a fairly long journey. There is another question. It's a bit long, so let me read it just to be true to the person who posted. Very inspiring. I agree. I definitely don't want to see an increase in the use of female animals in drug testing, but I am not sure if the sex of the human material in the non-animal tools, for example, organ chips, is considered. Is this something that researchers need to be aware of? And should we be requiring better reporting standards for an in vitro methods for publication, for example, to reflect this? Also, we don't want to make tissue chips more complicated or difficult to access, but can one organ chip constructed with female cells represent the whole sex? Are you aware of any studies that have considered sex differences in vitro, and the drug regulators how to bring them into the conversation? It's a long question, but the essence of it is that can we do this on experimental and using the artificial intelligence basis to mimic the sex differences in vitro, and then probably move from there? We'll be back to you, Maria Teresa, or any of your colleagues. I don't want to pick and choose.
I mean, I would just like to say quickly, and then I'll leave the mic to my colleagues, that this is a beautiful question, and we're looking into exactly this topic right now. We just had a hackathon organized by the Women's Brain Project, and one of the projects actually focused exactly on this question. And the understanding we had so far is that actually there isn't much awareness in this field of science about these specific issues, especially organs on a chip. But it has a huge potential for precision medicine. So we will actively try and perform some studies specifically in this field. And in general, I think awareness is increasing in labs and research organizations, and also different agencies, funding agencies are now requesting to specify the sex of the cells, the animals, and all that. But we are still far from, the ideal point. It's a very, very long journey, as you said, Samira.
Thank you very much, Maria Teresa. Anyone else would like to chip in on either of the questions?
I just wanted to add that there is a Europe-wide project or platform going on, and this was before the pandemic actually, with regard to drug development and prescribing drugs during pregnancy. So there is research going on. It obviously takes time and it needs to be done well, but I'm sure this will result in some helpful guidelines on how to move forward in this regard.
Great, thank you. And I have probably another question, and I'm not trying to abuse my holding of the floor and the mic. In the Kenya example, we saw the effect and the impact of the social behavioral change, and I was just wondering if there was a substantive and evidence-based difference in the social behavior between men and women and boys and girls for that effect as well. I mean, here in the United States, the mask wearing became a political battle. I mean, I dare say now. And we saw before and across their journey of the social determinants of health, how sometimes men do not wear protective gears, for example. I mean, people who work in airports, in the field, because it's not man enough to wear, those protective gears. So has there been anything that actually has enough data to make a conclusion, which we know about, is that women are actually more keen or less keen? I'm not trying to make a conclusion in the social behavior and in terms of how they communicate with regarding the protective gear of the pandemic. Thank you.
Well, if I may start with answering this question, well, it goes back to gender stereotypes and gender roles and how these influence our attitudes and behaviors. And in general, obviously we can only talk in general, because I am not for applying gender stereotypes. We are all individuals and we all behave differently. But in general, men tend to take more risks, while women are more cautious, which kind of adheres to the picture of the norms related to our gender. So this could also include also be applied to using protective gear. I also read a study about washing hands, where women were more likely to wash their hands more often. But still, it's very difficult to make generalized statements about this. There are differences in social behavior and health behaviors in various areas. And obviously, I think that we will, now when we will be studying these last months, the pandemic, we will also be observing differences in behaviors related to the pandemic and to protective behavior related to the COVID pandemic.
Thank you. Thank you very much. This I agree with you completely. I think the gender stereotypes usually cloud our judgment into all of these things. Any other last minute feedback or statements from our speakers before I close? All right. Thank you so much, our distinguished speakers from the Women Brain Project, for joining us this morning. We've had an interesting time listening to your experiences and putting evidence and science behind all of these differences that we are all struggling with. You're always welcome in this platform, so come back again, probably from another angle. And thanks to our colleagues who joined us this morning. And have a great rest of your day wherever you are. Thank you.
Thank you.
Thank you.
Bye.